My name is Anney Joseph. I am a reader with the TECS program based in Atlanta, and I'm going to go over the TECS program at the VA as well as teleglaucoma within TECS. TECS is the brainchild of Dr. April Ma. She is our Vision 7 clinical director for telespecialty, the TECS clinical director, and associate professor at Emory University. She began this program in 2015 and based it upon the VA's existing diabetic teleretinal imaging program. TECS now serves 38 VA facilities across the country, and we target the medically underserved to improve access to eye care. The Veterans Health Administration is the largest single-payer healthcare system in the United States. Many veterans do not seek care unless they're having problems. And this is evidenced by the top three services at the VA in highest demand, which are primary care, mental health, and eye care. Ophthalmology is not very conducive to synchronous or one-on-one type of telemedicine. It's hard to check vision and eye pressure accurately, and there's no slit lamp exam and no way to examine the fundus properly. So in order to examine and access the eye, teleophthalmology works best with a telepresenter. There are a few programs within the private sector using telepresenter in a synchronous method. However, TECS uses the asynchronous or store and forward telehealth model, which has been discussed previously. TECS is veteran-centric eye care using telemedicine technology to screen for diabetic retinopathy, cataracts, glaucoma, and macular degeneration. TECS is not meant to replace traditional face-to-face eye exams, but in low-risk patients, we can provide routine or follow-up eye care at a community-based outpatient clinic, which is typically closer to a veteran's home. The TECS exam consists of a telepresenter or an ophthalmic technician collecting information such as the history, chief complaint. They will check vision and perform refraction. They will check eye pressure and central corneal thickness. They will check pupils and assess anterior chamber depth. Then they will dilate the patient if the pressure, pupils, and anterior chamber are okay, and take images, send them to the server. They will input their information in the electronic health record and send all this information to the reading provider, who will interpret and make clinical decisions based on the information. They will enter any medications necessary, return to clinic orders or consults, and then they will provide feedback to the patient via phone call and or letter. They will also input and counter information for billing and coding. And this is an example of one of our TECS exam rooms with a dispensary. The goal of teleglaucoma in TECS is to provide glaucoma testing closer to a veteran's home, thereby reducing the time and cost to travel. Glaucoma testing procedures are ordered either by a TECS reader or the in-person face-to-face provider. These patients should not be new to our system. They should know they're coming in for a tele-ophthalmology visit, and the visit is identified as a teleglaucoma visit. In a teleglaucoma exam, again, the technician will obtain history, especially asking about drops and any side effects and last dose. They will check vision and refraction if necessary. They will check eye pressure and pachymetry if it hasn't been done already. They will assess pupils and anterior chamber depth, and then they will perform the ordered testing, either an OCT or a visual field. They will send this information to the reading provider, who will make their clinical judgments and any medications or follow-up. Some general rules on testing: we try and do one visual field and one OCT retinal nerve fiber layer a year, one set of disc photos every 3 years, and a dilated fundus exam performed in person every year. Severe glaucoma is not suitable for remote visits. These patients really should be followed and monitored face-to-face. Technicians can do visual field or OCT and dilated photos in one visit, but not both. And patients should know they will be alternating between TECS teleglaucoma visits and in-person visits. And I thank you for your time and attention.
My name is Alexa Liu. I'm the National Education Director at TECS, and I wanted to talk to you about some medical education opportunities at TECS. So we followed the 4 general principles of virtual learning when we created these rotations. One is a clearly defined goal or objective, and also the use of innovative tools and technology. We have a photo archive of common and uncommon pathology through the TECS patients. We also share the screen with our student and residents through meeting platforms to maximize flexibility. We try to engage the trainees' attention by doing this one-on-one and also in informal settings. And we actually encourage questions and try to answer questions as much as we can. We prompt them to give us anonymous feedback after each session, and this is through a quick survey through SurveyMonkey. This is our medical student 4th-year rotation that we have at TECS. The audience is geared towards a 4th-year medical student who's interested in pursuing ophthalmology in the future. They've completed their core rotations, and this is especially in demand during the pandemic, where in-person away rotation is hard to arrange. And this is also appropriate for students who do not have a home ophthalmology program. So the main objectives of the MS4 rotation are to gain knowledge in diagnosing, managing common ophthalmic problems. And they also gain knowledge in eye anatomy, history taking, abbreviation, and eye exams. They should be able to describe common indications and limitations of ocular telehealth in the primary care setting. And they get lots of practice on reading external fundus images, and when applicable, visual field tests and OCTs. And we also encourage them to understand the role and responsibility of all of the team members in teleophthalmology. They also participate in lectures and didactics. I'll highlight some of these. They go to the grand rounds lectures and resident lectures at Emory Eye Center, and also TECS attending lectures on topics such as teleophthalmology implementation, big data, artificial intelligence. They also complete a scholarly project with a mentor. Usually this is a case study that's interesting patient or a research project. And their final exam is 10 patients with external fundus images with history. And this is reviewed with an attending. This is a sample rotation calendar of a 4-week rotation. Our students also spend time in the OR and also in-person clinical time with the attending. This is the MS meeting platform that I mentioned previously, and we share screen and share also control. That way, the attending could point out interesting findings on the photographs, and the resident could, or the student could also follow along and be able to read the photographs themselves. The second educational opportunity we participate at Atlanta VA is through the teleprimary care rotation. And there are 4 other subspecialties who participate along with us: telederm, teleprimary care, urgent care, and pharmacology. So they do a 3-week rotation where they spend different time periods with different specialties. And these residents are family of medicine residents, preventive care medicine residents, PA residents, nurse practitioner students. And the objectives are based on the American Association of Family Medicine recommendations for ophthalmology. We also give them a handout on the systematic interpretations of photographs with pictures of common ocular disease findings. This is a pretty engaging 90-minute session. We'll start with a normal patient, look at the optic nerve, discuss what we're looking for on the optic nerve, and also what we're looking for in the macula, things that we might find in the vasculature and on the retina. And then we move on to a patient who has more clinical findings, and also, of course, a papilledema patient, because that's something they might be able to pick up with a direct ophthalmoscope. And common eye findings such as cataracts are discussed also. Lastly, I want to discuss the certification process at TECS. This is where new readers are trained to participate in the TECS program. And we're ever expanding programs, so lots of readers are onboarding. The audiences are board certified ophthalmologists and optometrists. The number one objective is always maximize patient safety. We do this by familiarizing all new readers with our protocol. And we also want to make sure all new readers are competent in diagnosis and also in be able to initiate treatment and also appropriate follow-up time. First, the didactics. All readers get these 4 items. One is our national handbook, which is updated periodically to reflect the current practice trend. And this is full of information on our protocol, on how diagnoses are called and different degrees, and also what the timeline for follow-up are. Next, we have tips and tricks on Vista Image, which is the software we use to store and forward our images. We try to maximize our knowledge of all the tools and buttons on this program. And then we have a cheat sheet for coding. And lastly, the self-study didactics include 4 practice patients who are real patients and how we read through the 4 patients and how patients are documented with tips on the side and explanations. So the second step in the certification process is a one-on-one session with an experienced reader. And this is done through MS Teams again. And the experienced reader basically takes the reader in training through a normal day, discuss how they manage patient load, documentation, coding, and communication with the patient. This is a great opportunity for questions. Last step in certification is the final exam. We have 10 real patients. A history, exam, and photos are sent to the reader, and they provide answers on diagnosis, follow-up plan, and time frame. This is then graded. We are expecting a passing score of 100%. If it's less than 100, the reader will be instructed to review and resubmit the answer for the specific patients that are missing. And if further discrepancies happen, the patient is discussed with the reader, and further training opportunities could be provided. And the local site, the site director is alerted. Once a reader has been trained, has been certified, all new readers undergo 10 chart reviews initially, and then there is a quality assessment of monthly local peer-to-peer review. Thank you for your attention. If you have any questions, please let me know. Thank you.
I'm Jennifer Lindsey. I'm the Assistant Chief of Ophthalmology at the VA Tennessee Valley Healthcare System, and I'll be talking to you about TECS outcomes, quality assurance, and quality control. TECS was launched in 2015 as a quality improvement project to improve access for rural veterans in Georgia. Early data published in 2017 indicated improved access as well as a lower cost of care, about $143 for routine screening via the TECS program compared to $291 for routine eye exam at the main VA facility. There was also lower travel costs, averaging $50 saved and 90 minutes of driving time saved per veteran. We served rural, very rural, and homeless populations, many of whom had not had an eye exam in over 5 years. Accuracy and patient satisfaction were also excellent, with patient satisfaction 4.95 out of 5, glasses remake rate similar to that of an in-person clinic, and disease detection for glaucoma, age-related macular degeneration, and diabetic retinopathy all over 90%, and cataract over 70% compared to face-to-face gold standard. Based on these preliminary successes, a clinical trial was started involving same patient on the same day, a TECS protocol versus a face-to-face exam. There was a high percent agreement between the TECS protocol and face-to-face. There was substantial inter-reader and intra-reader agreement, and a sub-project involving the addition of OCT demonstrated that this did not significantly improve agreement, indicating that this type of testing was not really necessary for disease detection in the TECS protocol. So how do we achieve these great results? We have a very rigorous peer review process. So this is an example of a form that one of our peer reviewers would fill out. A sample of TECS reports from each reader is reviewed by a peer. The expert reviewer goes over the report to determine agreement with the findings, diagnosis, and patient management. If areas of disagreement are detected, these are brought back to the reader, and if needed, the patient is contacted to change their follow-up or treatment recommendations. I'd like to shift gears a little and talk about future directions. TECS has been so successful in Georgia that it is now spread to over 38 programs across the nation. Most of those programs use this model, and we see this as a possibility for a national hub. Patients present to the VA eye clinic for care. The parent VA eye clinic then determines if this is a new patient or a basic eye exam. If so, they are sent to a TECS protocol at a community-based outpatient clinic. That location then sends the studies to a reading hub or reads the images themselves. Normal patients get glasses and may not need to get back into the system for some time. However, if the patient requires more intermediate, advanced, or procedural care, they are referred back to their parent VA for in-person care. At Tennessee Valley, we're beginning with 3 sites, targeting those areas with the greatest access challenges, again serving rural, very rural, and homeless veterans, providing basic care and glasses, and referring the more complex surgical cases back to the main campuses. As you can imagine, the TECS program has a profound impact on our veterans. We've been able to care for homeless patients, for rural and highly rural patients, many of whom have not had care in many years. We've been able to achieve greater than 90% access within 15 days of the original appointment request. The image quality is excellent, and the clinically significant disagreements from peer review are less than 1%. Perhaps most importantly, the patients really like the program and feel that they are getting great service. 97% felt that they had excellent or very good service, and 99% would refer another veteran to the TECS clinic. So we think it really serves as a great national model for the use of telehealth to deliver great patient care and improve access for our underserved patients. Thank you.